Hi, my name is Louise Organista and I'm a Frailty Pharmacist at Royal Derby Hospital. I'm presenting this poster on behalf of myself and my pharmacy colleagues Reena Gadu and Rupinder Rai. Our poster describes the impact and interventions of the Frailty Pharmacist within the ED Frailty MDT of our acute NHS trust. Currently, our role as pharmacists within the Frailty team involves assessing patients in the medicines admissions unit. We provide a service whereby we reconcile and optimise medications for patients identified with frailty according to our local frailty parameters. Our frailty team also assess patients within the ED setting, but as pharmacists we don't have an active role there. Patients merely having a physio and OT assessment as well as a nursing-led assessment before they are discharged. Since one of the frailty syndromes is about adverse outcomes to medications, and we know that overprescribing and polypharmacy can contribute to the presenting complaint of this patient cohort, we as pharmacists joined the frailty team for the trial of a new frailty assessment area within the ED setting to provide a full MDT-led CGA from June 2022. The service process involved identifying patients with frailty and ED by the lead frailty nurse. Once these patients were declared medically fit by the ED medical team, they were then transferred to the Frailty Assessment Area, or FAA, an area which provided additional space, confidentiality, and opportunity for the patient to rest, eat and drink, allowing a productive and patient-centred CGA to be carried out. The aims we developed for this service were to perform a pharmacist-led medication review and optimisation of medicines for the patients that were identified by the ED frailty team, to complete a pharmacist-led GP plan to ensure transfer of care where appropriate, and review if pharmacy GP plans were actually received and actioned accordingly. How this worked in practice, patients had a medication history completed by myself and my colleagues, and we requested reviews that we needed to help allow that, such as lying and standing blood pressure, observations and review of pain, and that enabled us to carry out a full medication review. In discussion with the patient and or their next of kin or carer, a plan was made to optimise the current medication burden, and non-pharmaceutical advice was also provided when needed. The summary was documented in the ED notes, and a GP plan was written to ensure transfer of care of information relating to changes in medications or appropriate follow-up that we recommended. Another role was that as pharmacist prescribers, we were able to prescribe medications that may have been omitted unintentionally within the busy ED setting, or whereby patients had a long wait and may have missed critical medications already. We ensured that appropriate pharmacy stock was procured to allow rapid dispensing of medications for inpatient and take-home use, which prevented delays to ensure discharge happened smoothly once the transport was ready. So from June to September in 2022, we saw a total of 73 patients as a pharmacy team of 3, with 208 interventions actioned. 92% of patients required some sort of pharmaceutical intervention. The most common intervention was a review of high-risk medications, and that was in 90% of cases. This encompassed medications which could increase the risk of a fall, postural hypertension, anticholinergic burden and bleeding, for example. Around 50% of interventions were about counselling the patient or the carer, an area which is equally important to amending a prescription. Providing advice could have been around pain management, could have been an example, giving advice around sleep hygiene, alcohol reduction, fluid intake, management of urinary incontinence. In about 40% of interventions, that was around requesting referrals, and that included referring to the GP for further monitoring or weaning or increasing doses of medicines, perhaps to discuss antidepressants, which we had maybe started the conversation with, or to check if response to recommendations were noted and actioned. We also completed referrals to the osteoporosis and fracture liaison team, mental health team, Parkinson's disease team, and back to primary care pharmacist if further support was required. Further interventions, as discussed previously, like observations and blood pressure, were requested in 38% of those interventions that we recorded. and 30% of interventions was about us prescribing medications. Deprescribing encompassed 23% of the interventions we noted, demonstrating that in this ED setting, it may not always be the most appropriate place to make those rapid decisions, or patients may not be in the right mindset to action a deprescribing decision or consent to that. So in majority of cases, we made suggestions and recommendations with the patient and asked the GP to follow up on those in a more appropriate time and place. In cases where a clear deprescribing decision was warranted, we informed the patient and or their family, and we spoke to them directly to make sure they were involved in that decision making. After about 4 weeks of seeing these patients, we then followed up the plans to see if they had been acknowledged in primary care and if they had been actioned accordingly. We had sought patient consent at the time of meeting the patient that if we could do that. We found that 65% of plans had been actioned and the rest had been left unactioned or unaddressed. We noted that it was usually the practice pharmacist who often followed up on the plan, and changes were made promptly within 1 to 2 weeks following the receipt of information. So it was very encouraging, as we knew that this key information was reaching primary care. As we reflect on what we did in ED, some of the strengths, this area which we worked in was a suitable area to consult with these patients away from the main ED setting. We had the opportunity to review and optimize medication and prevent future admissions or harm. Stock, which we were able to procure for use in that area, allowed timely administration of drugs to aid the therapy assessment, avoid delayed administration of critical medicines, and prevent avoidable deterioration in health, which ultimately hopefully would prevent a hospital admission in that care setting. Having pharmacist prescribers as part of the team ensured that we could prescribe medication, and we were able to action a medical plan if necessary in a prompt manner. We were able to request investigations to aid medical and medication management, and we always ensured that the patient and or their carers were counselled directly to make sure that any outstanding actions were highlighted and concerns were addressed. Another advantage was that we were able to relieve pressure from the medical team. As being experts in medications ourselves, we were able to use that skill set to allow them to assess other patients in different ways. Some of the limitations were that we noted not all GP surgeries were actively updating their record or checking discharge letters from ED, so some plans were not acknowledged. Some plans were acknowledged, but it was unclear if the changes had been actioned or there was a plan to be actioned. It was challenging to action some immediate medication changes. For example, if we recommended to stop a medicine that was in a blister pack, and that was more challenging, we had to be creative in ways to do that, depending on the patient's capacity to understand what was happening. And we would want to carry on doing this service 7 days a week with the rest of the Frailty team, but we would need additional funding to support the pharmacist workforce in that. Some suggestions then. So we would hope that we could maybe identify those GP practices with poor follow-up rates and contact them to make them more aware of the type of paperwork they would expect to receive from us in the ED setting. And we could use this data to look at perhaps bed days that we've saved by getting these patients home and discharged, and that might support a business case to fund a full 7-day full MDT service. In conclusion, our input as a pharmacist within the Frailty MDT ensured that the patient had a holistic and full CGA completed during the admission to the emergency department. The ED Frailty Pharmacist input reduced inappropriate polypharmacy and optimised medication for this patient cohort, with majority of care plans followed up appropriately post-discharge. A future study could examine readmission rates of patients in comparison to those without a Frailty Pharmacist input within a 6-month period. That is our poster and that's our presentation. Thank you for listening, and if you have any questions, please post them below. Thank you.